Hello everyone, I'm Dr. Anupama Chowdhry Devgan, your physiology faculty, and this is the daily quiz series in the run-up to the NEETPG 2025. We are in week 4, the last day for renal physiology and GI tract. I start with endocrinology and some miscellaneous topics from tomorrow onwards. So let's have a look at the first question. Which of the following is an incorrect pairing of the cell and the hormone secreted by it? The first one is G cell. G cell is in the pyloric antrum, the antral mucosa. And this secretes gastrin, which is true. Gastrin, what is the role of gastrin? It increases the HCl secretion. I cells in the upper small intestine secrete CCK. This is also true. What is the role of CCK? CCK causes a gallbladder contraction. CCK will increase the pancreatic enzyme secretion. CCK will potentiate the action of secretin. It enhances or potentiates the action of secretin, and this can also produce satiety. It acts centrally and produces satiety. The third is S cell produces secretin. This is also true, and the role of secretin is to increase the bicarbonate-rich pancreatic juice. It increases the bicarbonate content in the pancreatic secretion, making it alkaline, which is so important because the gastric chyme is acidic. To counter that, the intestinal secretions as well as the pancreatic secretions and bile have to be alkaline. K cells increases GLP. This is incorrect. K cells will secrete what is known as GIP, glucose-dependent insulinotropic peptide. What is the role of GIP? Earlier, GIP was known as the gastric inhibitory peptide, but the name has been changed to glucose-dependent insulinotropic peptide. This is because the physiological action of GIP has been found to be that it increases the insulin secretion. It does produce gastric inhibition of gastric motility and secretions, but only when the GIP levels are very high. That is why the name was changed from gastric inhibitory peptide to glucose-dependent insulinotropic peptide. What about GLP-1? The L cells secrete glucagon-like peptide 1. And the GLP-1 is another very important incretin. What is incretin? GI hormones which increase insulin secretion. GIP and GLP-1 are incretins. This also increases insulin secretion. In fact, GLP-1 is known as the physiologic beta cell stimulating hormone of the GI tract. Out of the two, GIP and GLP-1, it is GLP-1 which is more important. And today we know GLP-1 analogs are being used in the treatment of diabetes. They also have a role to play in weight management. Let's have a look at the next question. It says the first event in vomiting reflex is which of the following? Now, the very first event in vomiting reflex has to be antiperistalsis, a reverse peristalsis, where the intestinal secretions are pushed towards the stomach. So let's have a brief look at the vomiting reflex. There is a brainstem vomiting center, which can get impulses from area posterima, which is the chemoreceptor trigger zone. Area posterima is one of the circumventricular organs. What do I mean by that? That means there is no blood-brain barrier in this area. And that is why drugs, hormones can act on the area posterima, stimulating it, which in turn causes vomiting. The other important stimulus in the brainstem vomiting center comes from the cerebellum and from the labyrinth. This is what is responsible for the motion sickness or motion vertigo. Then also irritants in the pharynx, in the stomach, in the intestine can send impulses via the 9th and the 10th nerves to the nucleus of tractus solitarius in the medulla. and from there to the brainstem vomiting center, resulting in a programmed vomiting response. Now, the sequence of events in vomiting, the first one, like I said, is antiperistalsis. Second is a contraction of the abdominal muscles and which in turn increases the abdominal pressure. There's a relaxation of the lower esophageal sphincter. Respiration stops. There is elevation of the soft palate and closure of the airway by the glottis. Then a relaxation of the upper esophageal sphincter, and then the expulsion of the vomitus. But the first step would always be anti or reverse peristalsis. The principal site of sodium absorption is which of the following segments of the nephron? Now, sodium is a freely filtered ion. The filtered load of sodium. How do I calculate the filtered load of the filtration rate of any substance? This is GFR into the plasma concentration of that substance. Now we know that GFR is 180 liters per day and plasma concentration of sodium is about 135 to 145 milliequivalents or millimoles per liter. I'll take it as 140. This is 140 millimoles per liter. Liter and liter gets cancelled. If I solve this, this is almost 25,200 millimoles of sodium, which is going to be filtered by the two kidneys every day, which is a huge amount of sodium. This sodium has to be reabsorbed. We cannot afford to lose so much of sodium. We need to reabsorb this. So sodium is going to be reabsorbed in all parts of the nephron except the descending thin segment. And the maximum sodium absorption, 2/3 or 60% of the sodium absorption takes place in the PCT. Of sodium absorption occurs in the thick ascending limb. About 7% of sodium absorption occurs in the DCT, and the remaining 3% of sodium absorption occurs under the influence of aldosterone, and this is in the collecting duct. If there is a higher secretion of aldosterone, more sodium will be absorbed. If aldosterone is less, then less sodium absorption and more sodium loss in the urine. So the answer here is A, PCT. Which of the following will cause an increase in GFR? Now, when I look at the GFR, the major forces which are responsible for filtration are the two forces favoring filtration. The most important one is PGC, glomerular capillary hydrostatic pressure. Another force which favors filtration is PyBC, colloid osmotic pressure in the Bowman's capsule. Which are the two forces which oppose filtration? PyGC, colloid osmotic pressure of the glomerular capillaries, and PBC, hydrostatic pressure in the Bowman's capsule. So two forces favoring filtration and two forces opposing filtration. So anything which increases the forces favoring filtration will increase the GFR. Anything which increases the forces opposing filtration will decrease the GFR. So let's look at these different options. The first one says, if there is an increase in the resistance of the afferent arteriole, if there is an increase in the resistance, that means there is something which is producing a constriction of the afferent arteriole. If there is a constriction of the afferent arteriole, less flow into the glomerular capillaries. Less flow means there will be less hydrostatic pressure, which will decrease the GFR. Remember, hydrostatic pressure is the pressure due to a column of fluid, column of liquid. Second option, decrease resistance of the efferent arteriole. Please understand, if the efferent arteriole is narrower, then the outlet from the glomerular capillaries is resisted, or in other words, there is more resistance to flow of blood from the glomerular capillaries, so a back pressure will be created, which increases the hydrostatic pressure in the glomerular capillaries. But here's the opposite. There is a decreased resistance. That means now the efferent arteriole is dilated. So this reduces the hydrostatic pressure in the glomerular capillaries and reduces GFR. Increase in Bowman's capsule hydrostatic pressure. Remember I told you Bowman's capsule hydrostatic pressure is a pressure opposing filtration. So this will decrease the GFR. Increase in renal plasma flow. More flow into the glomerular capillaries, more will be the hydrostatic pressure in the glomerular capillaries, and this will increase the GFR. So the answer is D, increase in renal plasma flow. In the given image of the juxtaglomerular apparatus, which of the following structures acts as a sensor for detecting elevated sodium and chloride load in the tubular fluid? Now, juxtaglomerular apparatus has got three components. The first one is the macula densa. What is macula densa? Macula densa, these are modified tubular epithelial cells at the beginning of DCT. That means at the end of loop of Henle and beginning of DCT. These are modified tubular epithelial cells. So one are these macula densa cells. And what is the function of the macula densa cells? They act like a sensor. They detect sodium and chloride load in the tubular fluid. Older knowledge was that these macula densa cells detect only chloride load, but that's not true anymore. They detect both sodium and chloride load in the tubular fluid. Second are the JG cells. These are in the tunica media of the afferent arteriole, and these are renin secreting cells. The third are what are known as the Lassus cells. Lassus cells are the extraglomerular mesangial cells. What is the exact role of the Lassus cells? We are not very sure, but these three form what is known as the juxtaglomerular apparatus. So answer to this is A.